Dr. Watson. She is a pediatric endocrinologist at the Wendy Novak Diabetes Institute in Norton Children's Endocrinology, where she holds the prestigious Jack Henderson Chair of Pediatric Endocrinology. She serves as the medical director of both the Type 2 Diabetes Program and the Weight Disorders Clinic at Norton Children's Hospital. She is also an associate professor at the University of Louisville School of Medicine and holds a master's degree in clinical research. As principal investigator for the NIH-funded Kentucky Pediatric IDEA Research Center, Dr. Watson advances clinical trials access for underserved pediatric populations. So with that being said, thank you, Dr. Watson.
So thank you all. It is great to be able to talk with you today, and I appreciate everybody joining. So I think this was scrolling before the talk started, but just the mandatory disclosures. I do conduct clinical trials for a variety of different sponsors, but none of them pay me directly. So I really want to try and set the stage a little bit for our discussions about type 2 diabetes today, and start by talking a little bit about the changing prevalence of type 2 diabetes in youth, but also spending the majority of the time talking about the pathophysiology and some of the differences that we see between youth who are diagnosed with the disease and then how the disease manifests in adulthood. Most of what we know about the incidence of type 2 diabetes in youth comes from a study called Search for Diabetes. This study has been an ongoing observational study for quite some time, and it's at 5 different centers across the country. So this data presented here is the most recent incidence data that we have. It is over a 15-year span, and I want to kind of draw your attention to the purple X's. So that's the total data together. All of these other colors are breaking out the incidence rate by ethnicity. But taking the group as a whole, if you look at the incidence of type 2 diabetes between 2002 and 2003, the rate of diagnoses was 9 cases per 100,000 youth. And that rate almost doubled between 2003 and 2018, where it was 17.9 cases per 100,000 youth. It increased by significantly more in certain populations, particularly the Black and red shapes there, which are Native American and non-Hispanic Blacks. So when we look at why this is happening, and we really focus on what factors are causing all of these extra cases, and that's the risk factors. So we know that obesity is a big risk factor for type 2 diabetes, and the rates of obesity have continued to increase, and Kentucky is really impacted pretty significantly by this, and always ranking unfortunately high in the rates of obesity in youth. We also know that genetics plays a big part of this. So some of the GWAS studies have identified over 65 genes that impact insulin function and glucose metabolism, which increase the risk for type 2 diabetes. But the environmental factors, I think we talk a little bit less about, and they are a really broad category that includes everything from chemicals in the environment to just the buildings and how our buildings are designed, if they have stairs or not, and if you have access to green spaces. We know that the risk for type 2 diabetes in youth is different based on access to grocery stores and actually green spaces as well. And those built environment pieces really differ in different areas and communities. The exposure to the environment and its impact here starts really in the intrauterine environment, where we know that infants born small for gestational age, as well as large for gestational age, can have a higher risk of developing type 2 diabetes in childhood. sedentary activity and the high processed foods are the ones that we spend the majority of our time, I think, thinking about and focusing on. But we also do see quite a few people who are on medications that we know contribute to the development of type 2 diabetes. And then there are factors that we're still learning a lot more about. We don't fully understand the factors with the gut microbiome, though I think there's some exciting work going on in that area, so we'll learn more about that in the future. We know that other factors such as depression and a history of abuse and even immigration status can increase your risk of type 2 diabetes. So there's a lot more there that we still have to learn about and understand. I wanted to mention some about the endocrine disrupting chemicals because we do hear a lot about this in the news and on social media in the last few years. But these are really any chemicals that have the capacity to interfere with the endocrine system in some way. And listed here are pretty much all the ways that you can think about. You know, if it's changing the formation, the release, the transport, the function, you know, blocking the receptors for hormones. So we know that different chemicals can have significant impact. And some of the ones that we hear a lot about are found in plastics, are found in things like herbicides and fungicides. And then the PFCs we hear a lot about with the nonstick cooking surfaces. And I want to mention those in particular because we have really, I think, important information about how they impact genes that are related to health and weight. So the middle line here, all of those bubbles are just particular genes which we know these chemicals impact. And you can tell some of them stimulate the function of those genes and some of them block function. But the end result is that you have an increase in adipogenesis, increase in body weight, and some of them do alter insulin levels as well. Right now, the data that we have shows a direct link between some of these chemical exposures and obesity, but we don't have any data that says that those chemicals directly cause type 2 diabetes. So the risk is really through increase in weight, as far as we understand right now. We do know about a direct link between air pollution and causing type 2 diabetes. And that's true in adults where it's been described or established as a direct link. But also in youth, we have data that shows that that elevated nitrogen dioxide or particulate matter is linked to lower insulin sensitivity and poor beta cell function in youth. So we know that a lot of these environmental factors, which we don't have a lot of control over, are causing some of this increase that we see. But all of these risk factors are really driving two important changes physiologically that result in the development of type 2 diabetes. And that's through beta cell failure and insulin resistance. And the rate of disease progression is really determined by beta cell failure. So that's the key piece here. Children have a couple unique aspects that they are looking at when we're developing type 2 diabetes. And one of them is puberty. So we know that pubertal insulin resistance and weight gain contribute to the declining beta cell function. As children start into puberty, really at that Tanner stage 2, we see a decrease in insulin sensitivity. And these studies have been our gold standard insulin clamp studies, and they were done in healthy, lean individuals as well, that showed that you have this decrease in insulin sensitivity. It hits its lowest point in mid-puberty, and then typically after puberty, that rebounds back to the prepubertal levels. The change in insulin sensitivity that we see is about 50%. And individuals have to increase insulin secretion to make up for that change in insulin sensitivity. But when you have limited beta cell function, then you aren't able to keep up with that. So that's part of why we see a big increase in diagnoses of type 2 diabetes in that pubertal window. The other piece here is that obese individuals don't always return to the prepubertal levels of insulin sensitivity. So that insulin resistance persists. Overall, children with type 2 diabetes develop more rapid beta cell failure than we see in adults. So that progression to insulin dependence can occur in a shorter window of 3 to 5 years in individuals without treatment. So that also informs some of how we treat type 2 diabetes, which I'm not going to discuss, but you are going to hear about that more in the later talks. So I really like this graphic, but I'll tell you it is not perfect. So up at the top, it has some of the risk factors, and puberty isn't a lifestyle, but I think that it's just really nice to kind of put it all together. So if we start over on the right here, what we see is that excess lipids are deposited in non-adipose tissue. And that leads down here to where you have blocking of the insulin signaling pathways that lead to insulin resistance, especially in the liver. And that increases the liver's glucose production and weakens glucose uptake, which comes up to our middle section here where you have higher blood glucose levels. And then you increase basal insulin, which gets you to the top of that curve. The elevated insulin promotes more lipid deposition, and you just have this further aggravation of the insulin resistance, and you get this vicious circle that forms. But the elevated glucose also ties over here to the second circle where you have the increase in triglycerides. The increase in sugar and the lipids results in islet cell dysfunction. So it is also causing damage to the islet beta cells and lipid deposition in the islets, which prevents some of the secretion and also decreases the number of pancreatic beta cells, which results in further increasing in the blood glucose. So that's our vicious cycle that's causing type 2 diabetes. When children are diagnosed, so in adolescence, we do see earlier onset of complications in both microvascular complications and macrovascular complications when you compared to the expected rate in type 2 diabetes in adults. And I just want to share a little bit of the specific data. So this data on the diabetic retinopathy is actually from a meta-analysis of longitudinal studies in youth diagnosed with type 2 diabetes. And the length of follow-up for these studies past diagnosis went all the way up to about 17 years. But what they saw is that within the first 2.5 years after diagnosis, about 1% had retinopathy, but that increased pretty quickly. So in that next 2.5 year window, that rate increased to about 9%. But then the remaining group that was followed, so more than 5 years, the rate was about a quarter of them developed diabetic retinopathy. And like I mentioned, that follow-up period went to varied by study, but some of them went up to about 17 years. So a pretty rapid increase in that rate. We don't have a big meta-analysis for the diabetic neuropathy, so different rates have been published, but this was one of the larger studies in youth. This came out of Australia, and it showed a really rapid onset of neuropathy, where just over a median of a year after diagnosis, a quarter had peripheral neuropathy and half had autonomic neuropathy. Now, I will tell you, other studies have not had as high of rates reported, but I think it's important to just mention, because we need to plan to be to include screening for these complications earlier as part of our care for youth with type 2 diabetes. And the other thing that we can do to really try and prevent complications is to make the diagnosis earlier and control the blood sugars. So the American Diabetes Association recommendations for who to screen were developed for individuals who are at a higher risk, but who are asymptomatic. And for our patients, that's going to be youth who are overweight or obese and have at least one additional risk factor, including the maternal history of diabetes or gestational diabetes during the child's gestation, a family history of type 2 diabetes in a first or second degree relative, or other signs of insulin resistance or conditions associated with insulin resistance, such as acanthosis, nigricans, hypertension, hypercholesterolemia, PCOS, or that small for gestational age birth weight I mentioned. Screening should start after the onset of puberty or after 10 years of age, whichever occurs first. Type 2 diabetes has been rarely reported prior to the onset of puberty, and so that's why the recommendation for screening in asymptomatic individuals it starts at that point. The diagnosis is not different between adults and pediatrics. And so we can use a hemoglobin A1C for screening. None of our screening tests are perfect. I think we all know that, but we use the same threshold. So it's going to be a hemoglobin A1C of 6.5 or greater, or a fasting plasma glucose of 126 or greater. And then the threshold for an oral glucose tolerance test is the same as well. And I want to just mention when we talk about how to care for youth before they develop type 2 diabetes, so we diagnose them with prediabetes and we're trying to really prevent progression. We can address some of the risk factors, but we're focusing only on a few of the risk factors. So we primarily focus on weight loss, active lifestyle, and healthy diet. But I think it's important for us to remember that there are a lot of other factors that are impacting the pathophysiology of type 2 diabetes that we don't have direct control over, and our patients may not either. And so we have to try and remember those things when we're providing guidance as well as just our approach to care for these youth. So just the important takeaways, the pathophysiology of type 2 diabetes is universal, but there are some unique factors that contribute to the risk for adolescents that are probably also contributing to that rise in prevalence. And the disease is more aggressive when diagnosed in youth, with more rapid progression to beta cell loss and more rapid onset of complications. So our treatment and management is tailored to meet those challenges. So that's all I have. Thank you all.
Thank you, Dr. Watson, and thank you for being in DC at an NIH meeting and still presenting at this meeting today. Your dedication is appreciated. But you do have a question in the comment box from Dr. Folsom. She's saying, for the development of complications in youth with diabetes, did glycemic control influence the timing and/or incidence of microvascular complications?
So that's a great question. And so far, the data we have is yes, but we don't have the same level of data yet that that we have enjoyed from like the DPPT trial with, but so far the answer is yes. That's our primary goal, is maintaining glycemic control.
Okay. You have another question. This is from Dr. Lukai. Thanks, Sarah, for the nice summary regarding the risk for type 2 diabetes. Have you mentioned any sunlight risk for type 2 diabetes?
That's a really great question. So no, I haven't. You know, there is some data in adults showing that vitamin D Well, I can't tell you what level of vitamin D increases risk for type 2 diabetes. Normalization of vitamin D may help prevent progression from prediabetes to type 2 diabetes. So it is strong enough data that the Endocrine Society has recommended supplementation in adults with prediabetes and risk for type 2 diabetes, but we don't have data on that in youth yet.
Thank you. I have one question for you, Dr. Watson. You mentioned earlier genes, 60-something genes that have been associated with type 2 diabetes. When it comes to genetic testing, are these tests through research protocols, or should we be doing gene, or should we be looking at genes in children who present with acanthosis and prediabetes to say, holy cow, you're more at risk for progression versus not?
That's a great question. So that data is from research studies, whole genome sequencing studies that we do not do clinically. And I don't think right now for type 2 diabetes, we don't have enough information for me to recommend genetic testing and change our treatment based on the results.
Awesome. Well, thank you so much.